Okay, so I start recording the lecture, and I will start with the just brief overview and explaining about the GI disorders we're going to cover today, which is diverticular. Not, I mean, we'll have a whole like presentation on Thursday about the diverticular disease. So I will cover the IBD and then the hepatic and pancreatitis, like liver cirrhosis and pancreatitis. So IBD, liver cirrhosis, hepatitis. I have a few questions on hepatitis and then pancreatitis. So we have before we get into the IBD, which includes two diseases. One of them is called Crohn's disease, and the other one is UC, which is ulcerative colitis. We have to differentiate between the IBS, and sometimes you find, like, when you Google or, like, in textbooks, and you will see IBD and versus IBS, like irritable bowel syndrome and irritable bowel disease. Any difference between these two terms, IBD and IBS? So the irritable bowel syndrome, which is a chronic functional disorder, it is the manifestations of the IBS. It's like on and off, like intermittent, recurrent abdominal pain, stool pattern irregularities, like patients will go back and forth between like diarrhea, constipation, or even both sometimes at the same time, like like within like minutes, or like within an hour they will have like constipation and then diarrhea. So they go in between these stool patterns, irregularities. Now the cause of the IBS is unknown, but this altered bowel mobility, it is more heightened um, because of the inflammation. So this is there is an inflammatory um, process, and patients also sometimes the psychological like distress would likely to be involved. Sometimes is involved within the disease also with the IBS. And in addition to this, abdominal or GI symptoms, the patients also commonly they experience additional GI symptoms like abdominal distension, excessive flatulence, the sensation of like incomplete evacuation of the bowel, the urgency, bloating. So this is the IBS. But when we get to the IBD, which is covered in this chapter, or for this semester, we go over the IBD, which is an autoimmune disease. And I mean, scientifically, we kind of proved Crohn's more of autoimmune than the UC, the ulcerative colitis, but both of them we can see IBD. It's an autoimmune disease, although there's like an antigen probably that will initiate that inflammatory process. The actual tissue damage to the GI is due to the overactive, inappropriate, sustained inflammatory response. So there is like a strong and heightened inflammatory response that will lead to the tissue damage of the GI tract. So both ulcerative colitis and Crohn's disease, they're like very similar in terms of manifestations and disease like progression and disease process. And sometimes we have difficulty even differentiating between ulcerative colitis and Crohn's disease. So that's why you will find in the chart most of the patients will find like IBD only, and one out of like 100 you will find that this diagnosis is very specific to say Crohn's disease or ulcerative colitis. But in general, we sometimes have a difficulty differentiating between ulcerative colitis and Crohn's disease. And both which is IBD, both ulcerative colitis or Crohn's disease, they commonly occur during the teenage years and early adulthood. but have also there's like a second peak. Prevalence would be also heightened. High prevalence will be in the 6th decade of age. Like patients in their 60s, they will have like a heightened symptoms and augmented symptoms of the disease process. Patients with Crohn's disease or ulcerative colitis, they are very similar. So patients will have diarrhea, bloody stool. You will find the bloody stool more in ulcerative colitis more than Crohn's disease. Also, both will have abdominal pain, fever, fatigue, general weakness. Again, both conditions are very difficult to differentiate because they have a lot of common side of manifestations and symptomatology and disease process. Pretty much they are very similar. One of the differences between Crohn's disease and ulcerative colitis is that you will find that the damage to the GI tract is very intramural, like affects like the most of the tissues, especially with the absorption, and patients will have more of weight loss. And another difference in terms of the disease process, as you see here, that the ulcerative colitis, which is this one right here, is that it's like continuous inflammation of the lower or descending colon and the rectum. However, the Crohn's disease, it's like interrupted inflammation and interrupted damage to the GI tract. Most likely going to see that in like the ileum and the ascending colon. So that's another difference between ulcerative colitis and Crohn's disease. This slide, I just included, evidence-based practice, kind of an example of, of the IB for patients with IBD, and kind of investigated the studies looked at the and the question, the pocket question says that do adults adults with IBD have a higher risk of osteoporosis than adults without inflammatory bowel disease. So it just looked at the complication that may result from the IBD, which is osteoporosis. Okay, so let's go to question. All right, first question.
The nurse is teaching a client with diverticulosis about dietary management of the disease. Which foods should the nurse encourage the client to incorporate in their diet? Select all that apply.
So before we get to the answer, we have two different scenarios here. Patients with diverticulosis, that's the long-term chronic, and patients, they should be on suppose like we teach them to keep the high fiber diet, but when they develop diverticulitis, that's the acute phase of the disease process. So patients should be on a low fiber diet, low residue diet. So make sure that it is if the patient is experiencing a diverticulosis versus diverticulitis. Diverticulitis, that's the acute stage or phase of the disease process, and in which the patient should be on low residue diet. Two different dietary recommendations for two different conditions with the same disease. So this is a diverticulosis. It's not obviously that the patient is not experiencing acute phase of the disease process, supposed to be on high fiber diet. So we recommend patients to follow the high fiber diet, like
bran cereal.
Bran cereal is good. Yes, absolutely.
Beans.
Beans also. And also you can include broccoli, because that's vegetable too. So these are high fiber diets. So tomato juice and the cheese are low residue diet, should not be consumed for this disease. Second one, two.
A client is having an acute attack of diverticulitis. What should the nurse do first?
So in other words, that patient, if that was the question about the diet recommendations, patient should be on a low residue diet because this is the acute phase of the disease process. Now the question is asking about priorities,
Yeah.
In other words, the complications that that may could result from the disease it is peritonitis, right? So we have to assess for the client for signs of peritonitis. So complications of diverticulitis include like perforation with peritonitis, abscess, fistula. Fistula is also another complication. Bowel obstruction, bleeding. All these are expected complications from diverticulitis. The CT scan with oral contrast, that's a test of choice for for diagnostic testing for diverticulitis. Yeah, the answer is 3. You have to assess first for signs of peritonitis.
Okay.
Yeah, I mean the client or patient with acute diverticulitis does not receive a barium enema or colonoscopy because of the possibility. So this is like contraindication for them, right? The colonoscopy is contraindicated. It's not absolute, but it's contraindicated as much as we can to avoid it, because that can lead or because of the possibility of the peritonitis and perforation. So with the acute diverticulitis, and more for I would say high likely is that the patient during this acute phase disease process will be admitted to the med-surg unit or unit hospital. So the goal of treatment is to allow the colon to rest and inflammation to subside. That's our goal for this during this phase of the disease process of diverticulitis, is to allow for the colon to rest and the inflammation to subside. So a patient will be kept NPO. And as I said, that patient I would say most likely is going to be admitted to the hospital with, would be NPO and on fluids. So should be on parenteral IV fluids to be provided. Number 3.
A nurse is teaching a client about dietary methods to help manage exacerbation of diverticulitis. What does the nurse advise the client?
So this is the flare-ups of diverticular disease, and it's the acute phase. And we said during the
B1.
Two. Is it 4?
I think it's 2.
Or 1?
Low fiber.
So are we between?
I think it's 4, right?
We are between 2 and 4. And why 4 is correct. Remember, this is diverticulitis.
Aren't they supposed to be on a low fiber diet?
Right. Yes, should be on low fiber diet. So the answer is
2. 1.
On the
It's 2.
Why is 2? Yes. So if you go between
Because they're having a
low,
flare-up.
right,
So
yeah,
low fiber first, and then when it resolves, high fiber, right?
right. Mm-hmm.
So it is 2, yeah, 2.
Yes, exactly. That's what we just discussed earlier. Number 4.
Which is a correct statement differentiating Crohn's disease from ulcerative colitis?
Like Crohn's disease, like something specific in patients with ulcerative colitis. Let's say, which of the following is specific to the ulcerative colitis?
Hemorrhage.
Right, exactly. You'll find more hemorrhage in ulcerative colitis, like bloody stool, frequent, like more than sometimes like 10 bloody stool episodes of blood stool with ulcerative colitis more than Crohn's disease. Okay, next question, number 5.
A client is a newly diagnosed ulcerative colitis. What does the nurse tell the client about diet and lifestyle choices?
So we're trying to
The fourth
avoid
one.
the third one, lactose-containing foods should be reduced or eliminated from diet. So lactose-containing, because patient, so we attempt to eliminate all the irritants and irritating, food that would irritate the GI tract. So lactose-containing foods are often poorly tolerated and should be reduced or eliminated from the diet of patients with with ulcerative colitis. So that's lactose-containing foods, in addition to also the irritants to the GI tract. Number 6.
Situation: a 21-year-old woman has abdominal pain, cramping, and diarrhea. She reports having 10 to 12 liquid bloody stools per day. A stool sample for ova and parasites is negative. A diagnosis of ulcerative colitis is, and she is started on sulfidine. What does the nurse tell her about why she's receiving this therapy?
Okay, so this drug is a very, very important one that we have to go over and review it from pharm. It's the medication sulfasalazine that one of the side effects of this drug is that first of all, it's an anti-inflammatory drug, and it resolves the inflammation, because disease is all about the inflammatory process. One of the side effects is the photosensitivity in some patients. So the sulfasalazine is one also, as we said, one of the primary treatments for ulcerative colitis, and it inhibits as an anti-inflammatory drug, it inhibits the prostaglandin synthesis, and it reduces the inflammation within that mechanism. So the answer is
4.
4.
I have a question.
Yes.
So, someone with ulcerative colitis, their diet should include like a low fiber diet.
Diverticulitis. Remember that we differentiate between the verticulosis, right, versus diverticulitis. Diverticulosis, that's the disease that patients live with it, for right, and with some controlled like manifestations, not heightened or absent or not there, but at some point of the disease process, patient would have an acute episode of the disease. That's called diverticulitis, and that's when the patient kind of begins to experience all these heightened augmented manifestations of the GI symptoms and others, and then that's when the patient's supposed to be on a low fiber diet.
But like a
But
patient with ulcerative colitis, is that included in diverticulitis or that's a
no, that's different. The whole different disease.
so like
Diverticulosis is different than, yeah, the diverticulosis or diverticulitis, that's the pockets, there is a diverticula, which is like the pockets in the GI tract that's going to trap all these seeds, and they're supposed to be on like a low seed, or like, all these diet with seed should be avoided, because so that will not be trapped in these little pockets called diverticula. So again, diverticulosis is a whole different, it's not the same. It's not same as ulcerative colitis or Crohn's disease, and we differentiate between even the IBS and IBD.
I mean, so
at the
someone
beginning.
with ulcerative colitis should also be on a low fiber diet, or is that
No, diverticulitis, no, should be no, ulcerative colitis, yes, low fiber diet.
okay? Yeah, I was just asking. Okay, thank you.
Yeah, yes. Okay, next question.
A nurse is reinforcing the type of diet a client who has chronic diverticulitis should eat. Which of the following should the nurse recommend?
B.
Is it A?
Okay. Um, you know, Yeah, I think it's the same question, right? That we said diverticulosis, right? High fiber diet, diverticulitis, low fiber diet. So this one should be
A.
div- no, diverticulosis, high
B.
fiber diet. Diverticulitis, low fiber diet. So
B.
B, yes. So a client who has diverticulosis should eat a high fiber diet to prevent constipation and promote soft stools. So if the client develops the inflamed diverticulum, which is the diverticulitis, then the patient will be on PO, as we said, should be put also on initiated, or to begin the patient or sub-patient on IV fluids and low fiber diet, as tolerated. So high fiber diet should be resumed when the diverticulitis has been resolved. Okay, next.
A client who has muscular dystrophy and resides in an extended care facility is experiencing an exacerbation of irritable bowel disease. The client has been placed on lubiprostone. The client's diet has been suspected as being a contributing factor in relation to the recurrent episodes of irritable bowel disease. Which of the following foods should be eliminated from the client's diet?
So this is a patient with IBD, and that could be a Crohn's disease or ulcerative colitis, either one, because pretty much we go with the same diet for this patient. So foods containing dairy products, eggs, and wheat products, as well as caffeine, fructose, and sorbitol, all of these should be avoided. So nuts, grapefruit juice are not dietary restrictions. So patients can have with IBD. So again, this is not diverticulosis or diverticulitis. This is IBD, Crohn's disease or ulcerative colitis. Nothing to do with nuts will be, should be, avoided in patients with diverticulosis. But with IBD, they should not have
Milk.
eliminate milk, bread, because that's because of the wheat product, yogurt, custard and diet colas. I'm sorry. So the olive, because that's an irritant. That's because of the soda. So all but the first and last one should be eliminated or avoided. Next question. I think we did that one. Went over it. All right, we have a scenario case study.
A client who has Crohn's disease has been admitted for an acute exacerbation. A number, hold on.
Nurse.
A nurse is reviewing the laboratory findings for the client. Which of the following lab results should the nurse expect to find elevated in the client?
Yeah, this has to do with diagnostic testing in terms of diagnosing patients with ulcerative colitis versus Crohn's disease. You will find a lot of similarities also in diagnostic testing and results from these tests. And you will find there is because that's an inflammation. Remember that with the inflammatory process, there is any inflammation will lead to two things will be increased, right? The ESR and CRP, C-reactive protein, two things, in addition to the white blood cells. So in Crohn's disease, the ESR, which is erythrocyte sedimentation rate, and the white blood cells, they are elevated due to that inflammatory process of the disease, inflammatory aspect of the disease process. The hematocrit is low due to the chronic blood loss. So the malabsorption lead to decrease in folic acid and serum albumin. So you would expect to find these are the only two things that will be elevated. Everything else will be very low. Patient is anemic. Patient is losing lots of blood. Absorption is very had been depleted, very been reduced. So in Crohn's disease, patients have more issues with the absorption and then with anemia and weight loss more than patients with ulcerative colitis, given the pathophysiology of the disease process. But here we have, so patients supposed to have low hemoglobin, hematocrit, low folic acid, low serum albumin from the poor absorption, and then the ESR, the white blood cells should be elevated. So the only two elements of the disease diagnostic test to be elevated is the ESR and the white blood cells. Next, please.
Let's see, sulfasalazine has been prescribed to treat the client's exacerbation of Crohn's disease. Which of the following statements should the nurse reinforce when explaining how to take the medication?
And this drug actually it's an anti-inflammatory drug, or inflammatory process would subside from this medication, and also the drug can suppress or depress the immune system. So the immune system of a client who is taking the sulfasalazine can become depressed, or immune system is compromised, and subsequently will be vulnerable to infections.
So the answer is C.
Right.
Sore throat.
Yes. So the medication should be taken with food, first of all. The medication can be contraindicated if the patient or client is allergic to sulfa. This is very important. Sometimes you see this, question in the board exam, because the sulfasalazine, it includes part of, component of a sulfa in the drug. So patients who are allergic to sulfa, should be, this drug is contraindicated for patients with allergy to sulfa. But there is no contraindications with an allergy to penicillin, and this medication does not cause a change in the color of the stool. As well.
The nurse is teaching a client about managing diverticulitis. The nurse should teach the client to integrate which measure into their daily routine? Four.
Can you explain why, earlier?
Because I guess complications diverticulitis are like fistulas, and maybe the lifting would affect that.
I mean, fistula is, it's a long kind of, long-term like complications that could result from the disease process. But the problem with with the lifting and these activities that are going to increase the intra-abdominal pressure, and that may precipitate the attack. So, and the episode of the acute phase of the disease process. So, the clients with diverticular disease should refrain from any activities such as lifting or straining or coughing that would increase the intra-abdominal pressure and which may precipitate the attack. The enema are contraindicated because the enema also here is contraindicated because that may increase the intestinal pressure. Fluids or fluid intake should be increased rather than decreased, and so we can promote soft and formed stools. The low fiber diet is used when the inflammation is okay. 13, sorry, 13.
The nurse is instructing a client with diverticulosis about appropriate self-care activities. Which comments by the client will indicate effective teaching? Select all that apply.
So a patient who has diverticulosis should be instructed to maintain a high or low fiber diet.
High.
High. Okay, so that would be number 3, right?
5.
And
exercise regularly.
5 also, yes, and unless contraindicated. So what else? Fluids, right? Fluid, a minimum of 2,000 mL daily of fluid. So that number 4 also, right? So we have 2, 4, and 5.
Professor, I think you meant to say 3. 2 is laxative.
Oh, I'm sorry. Yes. Sorry, I said 2. Yeah, 3. Yes. Yeah, 3, 4, and 5. Yeah, so high fiber diet, fluids, and exercise. And the diverticulosis can be controlled with treatment, but cannot be cured. That was incorrect. So clients should be instructed to avoid the regular use of the cathartic laxative. So the bulk laxative and stool softeners may be helpful to maintain the regular bowel movement and to decrease the straining and Valsalva maneuver. All right, 14.
A client with diverticular disease is receiving psyllium hydrophilic mucilide. Which response from the client indicates to the nurse that the drug is having the intended effect?
And this should be like diverticulosis. So diverticulosis is treated with high fiber, and we just explained that few like more than once, right? 15.
A client with diverticulitis has developed peritonitis following diverticular rupture. When assessing the client, the nurse should perform which actions? Select all that apply.
Auscultate the bowel sounds.
Auscultate. Yes, absolutely.
3.
Fever.
3, 2, and 1. So we have 1, 2, 3, and 5. So the percussion will they allow for that resonance and the tympani, indicating any parodic ileus. We'll find out from that percussion if there is any parodic ileus from the resonance and tympanic sound. The lack of the liver dullness may indicate free air in the abdomen. So the client with the peritonitis, which is a complication, will experience like fever, tachypnea, tachycardia, the abdomen becomes rigid and rebound tenderness. Remember we said when that's a sign, major sign of peritonitis, and that's when there's also the absence of bowel sounds as well. The client will not demonstrate excessive thirst, but may have anorexia, nausea, vomiting as the peristalsis decreases.
Dr. Mickey, I have a question. I'm sorry.
Yes.
If
Yeah.
you can just go back to that slide. I was always under the impression that whenever a patient has like rebound tenderness or abdominal pain, they have like a board-like abdomen, like a rigid abdomen. We should not percuss or palpate the abdomen in order not to further complicate or cause the patient any pain.
Well, yeah, I mean, for the peritonitis, you have to assess the abdomen. Percussion is you can percuss, you can palpate, you can percuss. Peritonitis is not going to be exacerbated with with percussion. Yeah, it's not contraindicated in terms of assessment, like technique.
I see.
Yeah, it's not. But it's the percussion. It's contraindicated in patients with pheochromocytoma, and we're going, we will go over that, and the endocrine system. That's one of the absolute contraindications in patients with pheochromocytoma, and we'll explain more. Yes.
So for you, I know you said it's hard to differentiate between UC and CD, but let's say a patient came in and was complaining of bloody stools and stuff like that. So the first thing would that be stool cultures or fecal occult testing?
Well, the ulcerative colitis always, it's a gross hematuria. I'm sorry, a gross melena or like bloody stool. It's a gross. You can see the blood. It's not like a hidden or concealed or like fecal occult blood. It's not hidden. It's you can see the blood. It's bloody stool. So again, it's really difficult. I would say very difficult. That's why most of the charts the diagnosis will be like IBD without indicating if that's an IUC or a CD. But that bloody stool most likely is going to be ulcerative colitis more than Crohn's disease. Does that answer your question?
Yes, we're not doing no.
So yeah, it's very difficult. Again, you can review the the differences between them, and it's really difficult to differentiate between UC and CD. All right, so next topic is the hepatitis and then liver cirrhosis, or you can say liver cirrhosis, or equivalent to that would be ESLD, end-stage liver disease, similar to the end-stage renal disease, ESRD. So here we have either you can say liver cirrhosis, or which is the last stage or advanced stage of liver disease, which is irreversible damage to the liver. Or it's equivalent term to that is the ESLD, end-stage liver disease. So before we get to the chronic hepatic cirrhosis or liver cirrhosis, let's just talk a little bit about the hepatitis, in which also it's a presentation, I believe, this Thursday for one of the groups. Or maybe next week. Anyways, so the hepatitis viral. So we have it's a viral infection. The patients. So most cases of acute hepatitis are caused by infection of with like one of the 5 viruses. We have Hep A, B, C, or D, and even E. The disease or the hepatitis can produce virtually like indistinguishable clinical syndromes. Although it's unusual to observe the acute hepatitis C, Hep A, it's the route of transmission, or the mode of transmission is completely different than the other types of hepatitis, like oral fecal route in terms of like Hep A, hepatitis type A. And so the hepatitis A is found like worldwide. That is the most common cause of acute viral hepatitis in the US. And hepatitis E, that is much less common, and can find these cases of Hep A, for example, in like Asia and Africa and Central America and Caribbean. So the hepatitis B, which is the second most common type of viral hepatitis in the US, that is usually the transmission either it's bloodborne. And we know because it's bloodborne, so it has either the blood transfusions, which is, I would say, less likely is going to even see any cases of of Hep B due to that blood transfusion, because of the the testing and which took place like when we started the standards way back in the 70s, I believe, that most likely is going to see like these Hep B, because that's usually it's sexually transmitted. So that will be the IV, like drug abusers or users, and the like. So the Hep C, you will pretty much see most of Hep C, because that's parenterally transmitted by the blood transfusions or IV drug users. Hep C also as well is that Hep C, you'll find the majority of patients with Hep C due, like in patients with ESRD on hemodialysis, so they will contract the disease, if not through the sexual contact, will be from the contaminated hemodialysis unit. The Hep D, it's the defective RNA virus, but that requires the presence of the Hep B virus to replicate. So it can be acquired or a co-infection simultaneously with acute hepatitis B, or as a later superinfection in a like in a person with a chronic hepatitis B infection. When we say hepatitis, and then that, which is one of the high risk factors, or not the most, would be one of the risk factors for patients to develop the liver cirrhosis and end-stage liver disease. And so patients go through or under an experience, they will experience, or the pathophysiology of the disease process of liver cirrhosis. Patients or the liver will go through different phases, from like the fatty liver, and then towards which one of the phases of the disease process of liver cirrhosis. So hepatitis, maybe we'll hear more from the presentation about hepatitis and the treatment and diagnostic testing and manifestations, and acute versus chronic. So let's go over some of the questions.
A client is admitted to the hospital with a diagnosis of hepatitis A. Which precautions should the healthcare team observe when caring for this client? It would be gowning. Wouldn't it be gowning because they're on contact, but also wearing gloves as well? So gown and gloves.
Yeah, before we get to this question, which medication should produces or lead to high risk for hepatic toxicity or hepatic damage or liver damage?
Tylenol.
Acetaminophen, right? Acetaminophen. So 16 here. So patients with hepatitis A, we said this is the route of, the mode of transmission is through the oral fecal route, right? And the answer should be 4, right?
Yeah.
Yeah, gloves when giving direct care. So contact precautions are recommended for clients with Hep A. So the client or these precautions should include wearing the gloves for direct care. Gown is not recommended. It's not required unless there is a substantial contact with the client that is might be anticipated, like splash or whatever. There has to be another reason for the gown, but it's not necessary to wear even a mask, because the mode of transmission is through the oral fecal route. And it doesn't even require that the patient should be in a private room unless unless incontinent of stool. That would be a different story. Number 17.
The nurse has made rounds on a team of clients. the nurse should discuss which client with the healthcare provider. Number 2.
Yeah, ciprofloxacin following cholecystectomy 1 day post-op. For 1 day, I'm sorry, and has developed rash. Why 2?
Is that a symptom of some type of allergic reaction?
Allergy?
Yeah, so the yeah, I mean, the question maybe wasn't stated correctly, but it's supposed to, to say that which client you have first priority in terms of reaction or intervention, or so priority wise supposed to be the client with the baseline vital signs patients like with pulse 84 and now it's 118. So the pulse has increased and the rhythm appears to have changed. So with this elevated heart rate, the prescriber may request for or ask for a EKG to determine that the treatment is necessary.
So number 2 wouldn't be an option because the patient has been taking the medication for 1 day already, so you wouldn't be concerned of anaphylaxis?
Yeah, no. I mean, rash is not anaphylaxis. That's
No,
just
but I mean,
it's not rash that develops after the new antibiotic that started when we start new antibiotic must be brought to the provider's attention. But however, this is a I would say this is a stable and it's not the first priority. So it is change. Again, you have to kind of look into all these changes and see which one is more more critical. Rash, just the rash only. If there was a rash and respiratory difficulty, that would be anaphylaxis.
I see.
Rash, yes.
Is ciprofloxacin one of the side effects Redmond syndrome or SJS?
No, ciprofloxacin that's the fluoroquinolones. Cipro, like levofloxacin, ciprofloxacin, the floxacin suffix, that's the fluoroquinolones. And the side effect of these fluoroquinolones is tendinitis.
Tendinitis, okay.
Tendinitis, yeah. The Achilles tendon,
what could
most
be the rash on this patient?
I'm sorry?
What could be causing the rash?
Well, it could be, that might be, the patient can be allergic to anything. Yeah, patients can be allergic to anything, medication, food, whatever. But that's that the rash. So we have to investigate and see why patient has developed that rash. But if let's say like if you want to link it to the antibiotic, that's like a day after, right? So even though if you think of that rash is due to this or a side effect from or of that Cipro, we are going to not underestimate, like we're taking, like we'll consider it as a side effect at the point at this moment, like. So but we have to think, remember that this is only rash. There is no additional like more dangerous kind of life-threatening symptoms to start with. So we have to go to that patient, have pulse has jumped from 84 to 120 almost, and we will find out what's what's wrong with this cardiac parameter to have a tachycardia. So so we have to.
What's the for hepatitis? What could be the link for the cardiac irregularities? Is it part of the path of it, or like is the patient experiencing something that could be affecting the heart?
At this point, I don't have any association. Yeah, I'm not sure. Yeah,
Okay.
I can't link it to to specific liver disease at this point. But if that's an advanced stage, that could be the case. Yes, that's a complication from the advanced liver disease. Because sometimes patients develop like hepatitis and it goes unnoticed and untreated because it's especially because viral infections are self-limiting disease and patients just it's never been diagnosed with any hepatic. That's why you have to do screening and the titers and all of that, so we can identify and like diagnose patients at early stage. At some point, you have patients, people who do not like do any screenings and any blood testing, they will have liver disease, and until they experience these symptoms and disease process has gone into really wild kind of like advanced stage, an irreversible stage. So 18.
The nurse's assignment consists of 4 clients from highest to lowest priority. In which order should the nurse assess the clients after receiving the morning report? All options must be used. One, wait, from highest, 1, 3.
Yeah, so the nurse, right? So the nurse should first assess the client with cirrhosis to ensure the client's safety and assess the client for the onset of hepatic encephalopathy. Number 1, yes.
A 1,
And then
3,
3,
2, 4.
right. So for 2, that we should then assess this patient, number 2, sorry, 3, right? With the acute pancreatitis, because this patient requested the pain medication. So we have number 1, which is encephalopathy. We are going to explain more about encephalopathy, hepatic encephalopathy, and because of the safety, right, concerns. Number 2, which is pain management. I'm sorry, 3, pain management. 3, pain management. So pain medication should be administered. And then number 2, which is when they post-op following the cholecystectomy with T-tube inserted. Anyone knows what is, or can recall from Adult Health 2 about the T-tube, or what is T-tube?
Is that what drains the
Yeah,
bile?
it's a drain. Yeah, it's a drain, but it's it has a shape of a T, like a T, letter T. It goes right into the biliary duct, which is a cystic duct and common bile duct, and then the end of that tube will be exiting like in the skin and through like in tube, and it's like a drainage. It's post cholecystectomy, but it's not, I would say, widely or commonly like widely used now, the T tube. But still some surgeons, they kind of still use the T-tube, but we have to know understand the T-tube, its indications, complications, how to prevent these complications. So one of the things that have to maintain, the T-tube should continue to drain, and once it's stopped draining, like for a few days, couple of days, 3 days, then max of 1 week, then it will be removed. The T-tube, we supposed to have a especially like this is one day post-op, to make sure that this T-tube is draining and the client is performing post-op breathing exercises. So that would be 1, 3, 2, and then 4.
And Professor, just to be clear, the T-tube is only removed by the physician, not the patient.
Absolutely, yes.
Okay. Because it was
19.
A client with hepatitis C has been admitted to the hospital. The nurse should institute which measure to prevent transmission of the hepatitis C virus to healthcare personnel?
2. Yeah, would it be 2?
Yes. Hep C usually transmitted through a bloodborne or exposure or a needle stick. The hepatitis C vaccine is currently under development, but it's not available for use. And the first line of defense mechanism or treatment against the Hep B is the hepatitis B vaccine. And Hep C is not transmitted through the feces or urine, right? So the Hep A, that's the one that's fecal oral. All right. So liver cirrhosis. What is liver cirrhosis? Liver cirrhosis is the end stage or last stage, end stage liver disease, ESLD, and that's irreversible stage of liver damage. And there are too many risk factors or etiologies that may lead to the liver cirrhosis. And one of them, the alcohol, medications, cardiac. So each, even like, one of these etiologies is associated with the medical name of the liver cirrhosis, like the patients who may develop that liver cirrhosis due to the alcoholism that it's called Lennox cirrhosis, for example. Hepatitis also is another risk factor, like liver damage and liver infections, like hepatitis. That's a risk factor for liver cirrhosis. The complications that may result from liver cirrhosis, most important is the encephalopathy, which is hepatic encephalopathy, portal hypertension, another one, ascites, SBP, spontaneous bacterial peritonitis. So let's just review. I have an image here. Okay. There were some of the complications of liver cirrhosis. So patients with liver cirrhosis, they will have portal hypertension. So this is the portal vein that's going to drain one of the largest veins in the body that's going to drain all the venous blood into the liver for filtration and for detoxification. So the patients with liver cirrhosis, they have like let's say like this is like irreversible end-stage liver disease. That's like all the changes with necrotic tissues and necrosis going to lead to obstruction of the tubules and the channels within the liver. So it's like obstructed liver. So in other words, that this blood is going to be stagnant and less blood pooled in the portal vein, and blood right here pooling leads to edema and like engorgement and enlargement of the blood in the portal vein. In other words, there is a portal hypertension, more blood volume in the portal vein, high pressure. So more pressure here is going to create more pressure on the adjacent veins. Like one of the veins connected right to the portal vein is the vein that is going to lead or pour the blood into the esophageal the blood vessels, and that's why patients will have a high pressure within these blood vessels, capillaries, and lead to what is called esophageal varices. Easily ruptured, very weak blood vessels, easily ruptured, coughing, increased intra-abdominal, intrathoracic pressure would lead to the rupture of these, and bleeding, profuse, severe bleeding from the mouth. And then the pressure from the portal vein is going to exert more pressure on the kidneys, renal vein, also down to the rectum and sigmoid and the lead to what is called hemorrhoid. So lots of problems, complications that's going to result from the liver cirrhosis. Most of it due to this portal hypertension. Other complications associated with this disease, liver cirrhosis. The most important one is that the liver is now it's completely failed. One of the main functions of this liver is that it's supposed to detoxify or convert the ammonia to ammonium. Ammonia is a very toxic material or substance, especially for the liver, for the brain cells. The brain cells are very sensitive to the ammonia. this the liver is unable to convert it to the ammonium. Ammonium is a less toxic material. With the failure of this liver, then the ammonia will stay as ammonia, which is very toxic, especially for the liver cell, for the brain cells. And that's why patients with liver cirrhosis, they develop what is called encephalopathy because of that high ammonia content in the blood. There's going to be irritant and very irritant to the brain cells. Their patients will have a wide variety of, I would say there's like a broad spectrum of the encephalopathy. You know, the lowest would be like confusion and agitation and say, you know, like, you know, psychological kind of, alteration or changes to the patients become like combative, agitated, and it could also lead to the become lethargic and then maybe comatose, like, you know, hepatic coma. So that's because of the ammonia. And this ammonia, the source of the ammonia, two main sources of ammonia. The main source, or one of the sources, not the main one, but one of them is the flora, the normal bacteria, good bacteria in the GI tract produce some type of ammonia. Not that much compared to the ammonia, the main source from diet. So we recommend that patients with hepatic encephalopathy not to restrict the protein content. So low protein diet should be, you know, initiated for patients with, you know, hepatic encephalopathy, sorry, hepatic liver cirrhosis, because the protein is going to, you know, the byproduct from the protein is the ammonia, and there is no way we can convert the ammonia to ammonium because of the liver cirrhosis. So first of all, liver, you know, so low protein diet. Second is that we have to, measure the ammonia level in the blood and make sure it's within range. Whenever you have a patient with liver cirrhosis, presented to the emergency department with behavioral changes, agitation, combativeness, and all, and the like, is that we will, find out if that's liver cirrhosis. Then that could be that the ammonia level is very high in the blood. So testing for plasma blood ammonia level is required at this point. So we can, provide a treatment for that. Other changes or manifestations to the pathophysiology of the liver cirrhosis, we have something called spider angioma or telangiectasis or spider nevi. It's kind of small, tiny blood vessels going to rupture and result in something looks like this, like the spider nevi, like this one. This either in the facial, like face, or you can see it also on the abdomen around the umbilicus as well. And that's small dilated blood vessels with the bright red center point and spider-like branches. That's again, nose, cheek, upper trunk, neck, shoulders, around the the umbilicus, like in the abdomen. And the another complication, which is this one right here, which is the palmar erythema, which is a red area that blanches with pressure located in the palm of the hands. And both of the spider angiomas or the palmar erythema, both of these kind of complications or manifestations of the liver cirrhosis, the can be attributed, we can attribute this to the increased estrogen hormone, because the liver supposed to metabolize the estrogen. So the inability of the failed liver to metabolize the estrogen, that's going to lead to more production of these small tiny blood vessels, and which we will be presented in terms of the spider angioma and the palmar erythema. One last things that, or two main things also with the liver cirrhosis, is that patient will have ascites, huge abdomen. Anyone of from the group has ever like took care of a patient with liver cirrhosis with the abdomen, like in large abdomen or ascites like this?
I have. They had to do like a paracensis.
Right, and you can see all this.
Remove.
You have the scar tissue right here. All the scar tissue has to, it's all the resultant scars from the paracenteses, because we have to drain this trapped fluid, which is third spacing fluid in the abdomen, peritoneal cavity, has to be aspirated with large trocar, like in large needle, and that's paracenteses. So the this is very, I would say, classic kind of, abdomen for patient with liver cirrhosis with these little tiny, scar spots, which kind of, you can associate that with the how many times patient will undergo these paracentesis. Sometimes I have seen patients experiencing like twice a week, 3 times a week. Others would like, once, every 6 or 7 months or once a year. It depends on the, the progression of the disease process, or depends on the stage of the disease, how advanced the stage is, and the complications and patients' compliance with the regimen and food and everything. And the last thing is that we have also something called asterixes. Asterix is a flapping tremor, and this is this is one of these sign of. You can see it in patients with liver cirrhosis, as in similar also to patients and with end-stage renal disease. So here with liver cirrhosis, the asterisk says, how would you, this is like in physical assessment, you will, should learn about this, how to elicit the asterisks, how to elicit this asterisk, which is a flapping tremor. So have the client extend the arm, dorsiflex the wrist, and extend the fingers. You will observe that the patient will have like a rapid, non-rhythmic extensions and flexions of the palm or the fingers. So that's kind of how how would you test for the asterisks. All right, so let's go back to our question, which is 20, right?
A client had a liver biopsy 1 hour ago. What should the nurse do first? Check for fever.
Check for fever.
Biopsy. So the biopsy needle inserted, the site, or even like insertion site, is very close to the lung. So there's a risk for lung puncture and pneumothorax. So therefore, immediately after the procedure, we should determine diminished or absent lung sounds in the right lung. So the answer is
number 1.
1. So another, what other nursing implications or nursing interventions actually here for patients post liver biopsy? Something very important. Remember that the liver is highly vascular organ. You anticipate bleeding hemorrhage after the biopsy. So you have to stop the, if there's any bleeding, we have to even to kind of like, like applying pressure, in other words, applying pressure post, similar to the cardiac cath. Remember that cardiac cath, with the groin, and we have to put pressure. Same thing here. So we have to apply pressure. What kind of pressure you can apply positioning wise in patients after liver biopsy? So because temperature is not going to be seen immediately, so the rise in temperature will not be seen immediately. The CBC is warranted when, if the vital signs and client symptoms indicate potential hemorrhage. So we don't do all of this unless there is a sign of hemorrhage. Now, the needle insertion also site is covered with a pressure dressing. Therefore, there is no need for any dressing required or any packing. What kind of position? My question was which is position wise. Said position important post, right after the liver biopsy.
Right lateral.
Right side lying.
So right, I mean, you don't have to be right, but it should be yeah, I'm sorry, right side. Yeah, you can see like supine, like prone, not supine, prone position with right side, kind of like more leaning to the right side. So we can apply pressure, and then we have a pillow, so that will create like pressure on the insertion site. Pillow, lean, and then prone position, like with the patients on in their abdomen, right? And then the right side, leaning more to the right side. So we have prone position, pillow under the abdomen, leaning more to the right side, but it should be prone supine position. Prone position. 21.
A client with cirrhosis is receiving lactulose. The nurse notes the client is more confused and has asterixis. What should the nurse do next?
Which is whenever you see asterisk means it indicates there is an patient is experiencing a advanced hepatic encephalopathy. Advanced hepatic encephalopathy. It's one of the signs of advanced encephalopathy or liver, like cirrhosis. In other words, there is an increased ammonia level.
Withhold the lactulose?
No, lactulose is great. It's a good, it's a perfect drug for the high ammonia. Remember that one of the treatments for the encephalopathy with high plasma ammonia level is that we will give patient lactulose. Patient will be actually on lactulose. That's one of the drugs that patients do, dislike, and they don't like to take it at all because the lactulose makes them go to the bathroom several times, like over like 2-3 hours they'll go to the bathroom because that's like stool softener. At the same time, lactulose will trap the ammonia and remove it with the blood, with the bowel movement. So lactulose creates that the diarrhea at the same time is going to trap the ammonia and release it and remove it from the GI tract. So it's good. Lactulose is one of the best medications, but again, most patients don't like it because of the taste and also because of the frequent bowel movement. But that's anticipated. But we have a new drug, very effective, way better than the lactulose, and it's not liquid. Lactulose is a liquid form. The other drug, the new drug, for I would say fairly new drug called rifaximin. And it's a anti-infective plus like anti-inflammatory. Like it takes care of the ammonia. At the same time, it will eradicate the bacteria from the GI tract. And why would you eradicate the GI flora or the good bacteria? Because again, that's a source of protein. I'm sorry, ammonia. It's a source of ammonia. And when we eradicate, like sterilize the GI tract with the anti-infectives, like the streptomycin, neomycin, or with even rifaximin, which is Xivaxan or rifaximin, we eradicate in the same time we will remove the ammonia from the GI tract. This drug is very effective. It's a tablet. It's less like problems or side effects similar to the compared to the lactulose with the frequent bowel movement, patients do not experience that with rifaximin, or Xivaxan, rifaximin or Xivaxan. This is a very important drug. Write it down. And it's compared to lactulose is very an excellent drug compared to lactulose, but it's very expensive. As I'm not sure if that's still very expensive at the moment, but still, as a new drug, it's still expensive compared to lactulose. That's why you will find patients on lactulose, and I have seen even patients on both of them. It depends on the severity of the disease process, but again, lactulose is very cheap compared to the Xivaxan, rifaximin. So patients, so the answer should be
4.
Would it be 1?
1.
One?
What would you do, bilirubin? So it should be 1. Yeah, clients with cirrhosis, they can develop the hepatic encephalopathy caused by the increased ammonia level, plasma ammonia level. So the asterisk is just a phlebic tremor that is a characteristic symptom of the advanced, right? Increased ammonia levels. So bacterial action, the action of the bacteria on increased protein in the bowel will increase the ammonia, and that will lead to encephalopathy and make it even worse. So the GI bleeding and the protein consumed in the diet that would increase the protein and increase the ammonia. So in other words, that we should encourage the low protein diet. The lactulose is very effective to treat that. So bilirubin is associated with jaundice. So bilirubin has to do with jaundice, not the asterisk is. So then, number 1, right? 22.
The nurse is assessing a client with cirrhosis who has developed hepatic encephalopathy. The nurse should notify the healthcare provider of a decrease in which serum lab value that is a potential precipitating factor for hepatic encephalopathy.
A decrease in which serum lab? It should be hypokalemia. Potassium. Yeah, hypokalemia is the precipitating factor in hepatic encephalopathy. Decrease in creatinine that would result from the atrophy of the muscle atrophy. And any increase in creatinine we know has to do with with renal insufficiency or renal damage. So with the liver dysfunction, there is an increased aldosterone. We will see high aldosterone. That's with the liver dysfunction. The decrease in the serum protein will decrease also colloid osmotic pressure as well, and lead to edema. So the hypokalemia precipitate the hepatic encephalopathy. 23.
A client has advanced cirrhosis of the liver. The client's spouse asked the nurse why the client's abdomen is swollen, making it difficult to fasten their pants. How should the nurse respond to provide the most accurate explanation of the disease process?
So patients with liver cirrhosis, remember that they have this ascites and protruded or distended abdomen. That's from the fluid leakage from the blood vessels into the peritoneum. What makes the disease even more, I would say, worse and advanced is that the leak of this fluid from the blood vessels into the peritoneum, it takes some protein with it. So the leakage of the protein molecules from the blood vessels into the peritoneum, it makes the situation even worse, because that's going to pull more fluids from the blood vessels into the peritoneum. So that's why it's like constant, kind of continuous problem. And I've seen patients, undergo this paracentesis once or twice a week, and with a large amount of fluids being aspirated or removed from the abdomen. So okay, Arlene, go ahead. Sorry.
Would that be number 4 then?
Absolutely. So portal hypertension and hypoalbuminemia as a result of the liver cirrhosis, they can lead to a fluid shift into the peritoneal space, causing the ascites. In cardiac or kidney problem, not cirrhosis, the sodium can promote edema formation and subsequent decreased urine output. So that's the explanation or the rationale for this question.
So a quick question, Professor. So the patient has more protein in their stomach and the fluid. So
not
the
the stomach.
fluid is
It's not the stomach. It's peritoneal cavity.
I mean the peritoneal cavity.
Yeah, peritoneal cavity.
With that increase, so with the increased protein, they're also pulling more water because of increased oncotic pressure?
No, oncotic pressure is always, oncotic pressure is protein. So they would have a low fluid volume. You can say it's not significant to the point that it will be significant, but it's pulling the fluids. A patient with liver cirrhosis will be on fluid restriction anyways, because the fluid is going to be filtered or leaked to the peritoneum, and more protein leaving the blood vessels to the peritoneal cavity. So the blood vessels would have less protein, so that will lead to the hypoalbuminemia or hypoproteinemia, and that could be also another pathophysiological reason or etiology for the edema. They develop edema as well of the lower extremities, and that's due to the loss of the protein in the abdomen from the blood vessels to the peritoneal cavity, because we have to remove the fluid with this protein leakage through the paracentesis. So patient will end up with less protein, less albumin in the blood vessels, and that's why they develop also the lower extremely spreading edema. Ola,
Okay,
that explains your question, Ola?
yes, yes.
Okay. All right. So I think we have to stop because I have another class in 15 or like 30 minutes. Any questions? We'll continue on Thursday.
Dr. Mickey, me and Sandy
Yes.
have a capstone meeting with you at 2 via Zoom, just reminding you.